let's just say he's having problems with his left hip. Okay, now he's not going to be in this position. He's going to be standing there. He's not going to lay down on his back. He's not going to move until you tell him what to do, right?
Yes.
So patients, you cannot help the doctor out in any way. You're going to stand there as an ignorant patient, right? And so he's having problems, and he's internally fixated on the left. So you're going to have the patient lay supine. You're going to bring this up with your freezing cold hands. And then what you're going to do is internally fixated. That means it's not going to move into the externally rotated position. So you're going to look at the externally rotated position, keeping these and these at 90 degrees. You can stand like this, it's fine. And say, okay, it moves this far. This is the one that's internally fixated. So I'm going to get up. It's not moving as far into the externally rotated position. So you can then pivot to the superior and grab the anterior part of the greater trochanter, thrust. Or if the patient's larger than yourself, Eric, come on down here. All the way down. There you go. And I'll sit down, lay back like that. You can bring this up like this. We're going to increase the external rotation. Remember, the patient's knee always goes, or the patient's thigh will always go over your medial shoulder. You're going to grab the anterior part here of the greater trochanter. Take this hand for stabilization and assistance, and thrust to increase the external rotation. Okay. Then you'll go over to Charlie, and we may ask you, okay, what is internal and external rotation? You would say, okay, this is external rotation, this is internal rotation. It's fixated in the internally rotated position. The contact point is a hair on the anterior part of this. It's not going to move. Since it's internally fixated, it's not going to rotate externally.
Thank you.
Okay, so if he has an externally rotated, and remember, you have to always show us the good side first. You actually are going to do the examination on the good side. Okay, so, but we're just going to forego that now for these. If he is fixated externally, he's not going to go which way? He's not going to go internally. So you would look at that, you would monitor that. You can adjust that this way to increase that rotation. Some people like to hold on like this, that's fine. Or you can take the patient, put them like this. Try to keep this at 90 degrees. Contact the posterior portion of the greater trochanter. Bring the patient into position. Thrust. Okay. Okay. Let me have you sit up. And face that way. Let me pull this back over there. Have a seat, sir. Have the patient scoot all the way out on the table for this part of the examination of the knee. You got to do that. Don't forget. What we're looking for here basically is the open wedge. Right? So we'll look at the femur. And so let's say his femur. And the only femurs I've given you are the medially displaced femur. Once it's medially displaced, it can be anteriorly or posteriorly rotated, right? So if his problem is on his left knee, he'll just stand there until you tell him where to go. And you're going to come up and you're going to motion palpate like this, okay? What I'm looking for in particular is this to open up on the outside when I move him laterally, or not close down on the inside. Because if it's fixated medially, right, if it's a medial femur, it's not going to go lateral. So when I'm doing my motion palpation, that's the motion I'm particularly interested in. Okay? So I'm going to come over onto this one here. We want to try to keep everything at 90 degrees, stabilize the foot, move it back and forth. So we're going to say that he's having a fixation component. It's not closing down medially here on this side. Okay? If it's anterior, then we're going to, or posterior, doesn't matter, move the patient back onto the table. You want to leave about 6 inches hanging off the table so you can get your hand inside there. Come up, grab onto the patient like this. I want to make sure that you guys can get to the patient's knee. We're going to turn the knee. You can do it like this. It's fine. I'm going to bring the femur, which is anteriorly rotated medially here, back into a more normal position, and I'm going to thrust across here. You may want to have your CA stabilize that. Or you come up like this, do some stabilization this way. I think this is a stronger move. come up, grab a hold of it, make sure you're stabilizing the tibia, and lean this in with my elbow, putting a varus stress here, thrust across. Okay? Or if it's posterior, medial and posterior, I'm going to turn it this way, keep it up like this. I'm going to now take my hypothenar, my pisiform, put it on the posterior portion of the femoral condyle, and I'm going to thrust across this way. In practice, you can try varying degrees of knee flexion. It will help you with your adjustment. Okay? It's a tough bone to move, but you can do it. So that's the femur. Any questions on that? Any questions on anything so far?
Is it usually the same mechanism causing fixation as in vertebrae with extremities?
I think it's a ligament. And in the vertebrae, I think it's a disc, which of course is a ligament. I think there's a ligamentous lock that causes the problem. After a while, the muscles are going to change.